Welcome to the New England Journal of Medicine at the annual meeting of the European Society for Medical Oncology. I'm Stephen Morrissey, managing editor, and I'm talking with Eric Rubin, editor-in-chief, and Oladapo Yeku, associate editor of NEJM Evidence. We're looking at the Niagara study, Perioperative Durvalumab with Neoadjuvant Chemotherapy in muscle-invasive bladder cancer. Yeku, this is the second study of immunotherapy in bladder cancer we're discussing at ESMO, but this time with a different agent, Durvalumab. How much do we know about the relative effectiveness of the different checkpoint inhibitors?
So, Steve, these treatments are hard to compare because not only do these trials study different drugs, notably made by different companies, they're also different things. Durvalumab is a PD-L1 inhibitor, pembrolizumab is a PD-1 inhibitor, but they also look at them in these trials for different populations, such as platinum-eligible versus high-risk disease with any platinum exposure, and they also look at them in different settings, perioperative versus maintenance.
Eric, what did this study show?
Steve, in this open-label trial, patients with muscle-invasive bladder cancer who were eligible for treatment all received neoadjuvant gemcitabine and cisplatin prior to a radical cystectomy, but were randomized to receive additional neoadjuvant and adjuvant Durvalumab. The primary outcome was event-free survival, with overall survival a secondary endpoint. A total of about 530 patients were randomized to each arm. Event-free survival at 24 months rose from almost 60% with placebo to almost 68% with perioperative Durvalumab. Overall survival also increased from just over 75% to just over 82%. Both values were significant. Adverse events were similar in both groups.
Yeku, is there any consensus on which approach is better, perioperative chemoimmunotherapy treatment or adjuvant maintenance treatment?
Unfortunately, the way many of these trials have tested these approaches are designed to limit cross-trial comparisons. The patient populations, number of cycles of treatment, and histologies and stages of disease enrolled are only but a few factors that limit these comparisons. There are hypotheses, however, to support the role of perioperative immunotherapy when there is a relatively large tumor antigen burden available for sampling by the immune system. But there's also a hypothesis to support the use of adjuvant immunotherapy for patients with high-risk disease when there is likely micrometastatic disease that might be more amenable to immune attack. For diseases such as muscle-invasive bladder cancer, where the mortality from recurrent or progressive disease is very high, controlled head-to-head studies will need to be conducted to answer these questions and determine the optimal setting and duration for the incorporation of immune checkpoint inhibitors with standard of care chemotherapy.
Yeku, I've always found it interesting that you can combine immune checkpoint inhibitors, which require a cellular response to work, with chemotherapy, which often would inhibit that same kind of cellular response. Is it likely that only certain chemotherapeutic agents can be combined successfully with checkpoint inhibitors?
For diseases such as muscle-invasive bladder cancer, where the mortality from recurrent or progressive disease is very high, controlled head-to-head studies will be needed to answer these questions and determine the optimal setting and duration for the incorporation of immune checkpoint inhibitors with standard of care chemotherapy.
Thank you, Yeku. Thank you, Eric. The report of this study is now available at nejm.org.